everyone.
Okay.
First of all, I'd like to
Please.
thank Minu for inviting me to participate in this instruction course. And today I'll be speaking on femtophaco advantages and limitations in challenging cases. These are my financial disclosures with no relevance to my talk today. We're all familiar with the dense brunescent cataract. It's difficult to create a capsulotomy because of the absence of red reflex. There's also a thick, bulky nucleus and a leathery posterior nuclear plate to deal with, and therefore we often have to apply high ultrasonic energy, which may cause a wound burn or corneal edema postoperatively. With the aid of the femtosecond laser, we are able to easily create a perfect, well-centered capsulotomy, and also it helps us with the separation of these leathery fragments because it has been pre-cut, and in this case I had pre-cut the nucleus into 16 segments, or you can also do grid segments that also help to reduce the ultrasound energy used. So this is a wide intumescent cataract, and we are all familiar with the high intralenticular pressure that is associated with that high risk of Argentinian flag sign as we puncture. Now, if we are successful in decompressing the nucleus on puncture and we do not get the Argentinian flag sign, the capsulorhexis still tends to run away in the mid-periphery because of the swollen lens fibers. So what is the best way to tackle these cases? I like to use the femtosecond laser. So let's have a look at how this performs. You can see as the laser hits the capsule, there was a sudden explosion as the fluid egressed suddenly from the lens capsule. And therefore, it's important to first run intravenous mannitol to medically decompress this lens that's very swollen. Secondly, when we apply the suction cup onto the eye, we want to try to achieve a level dock so that the laser hits the anterior capsule simultaneously and is able to complete the cut. Despite these measures, we may still have an incomplete capsulotomy. And therefore, it is very important to stain the anterior capsule with trypan blue and to check for completeness. And if it's not complete, we want to make sure that we complete this either with the capsulorhexis motion if there are bridges, or if they're text, to just pull radially inwards. In a study that we performed and published, we found that 17% of our capsulotomies in intumescent lenses were not complete, and in the Chinese paper they reported 10% incomplete, but importantly, none developed the Argentinian flag sign. Now this patient whose lens is getting more ganglion, you will see that there is a thick subcapsular fibrosis that has developed, and we will be really challenged to try to tear this and create a perfect capsulorhexis, but with the aid of femtosecond laser, we can get that perfect capsulotomy. Now, when we have a patient with corneal opacity, like what we see on the left, spheroidal degeneration, or on the right, granular dystrophy, can we use the femtosecond laser to help our surgery? And you can see if the scar is faint, as on the left, we are able to create capsulotomy and fragment the nucleus successfully. However, on the right, where granular dystrophy causes a denser opacity of the nucleus, it does impede the laser treatment on the capsule and on the nucleus, and therefore we get skip lesions of the capsulotomy, and these cases are best avoided. Now this is a patient with acute angle closure glaucoma. You can see that the lens is slightly decentered and it is extremely shallow anterior chamber as the lens is being pushed forwards, and we'll be very challenged to doing the capsulotomy manually. But this is rapidly done with a femtosecond laser as we scan the capsular bag and center it on the nucleus. So when the patient is brought to the table, you can see the cornea is really hazy because of the high pressure, and we do a limited posterior pars plana approach to dry vitrectomy to decompress the eye, not to make it too soft, otherwise surgery would be difficult. We release the peripheral anterior synechia before starting the phaco. So you can see after the capsulotomy is removed and this was complete, we then support the nucleus with capsule bag hooks and then remove the rest of the cataract. Now this would be far more difficult to do if we did not have the aid of the femtosecond laser to create that capsulotomy in this very, very shallow anterior chamber and a lens that was decentered. Because it was scanned to the capsular bag, we can get that perfect centration of the capsulotomy on the lens capsular bag. So if we have a patient with a small pupil, can we use the femtosecond laser? Yes. First of all, we want to stain the anterior capsule and then we inject cohesive viscoelastic, following which we inject in a Malugian ring to expand the pupil, and we center this Malugian ring so that we are able to center the capsulotomy with the laser. We then apply the suture before doing the treatment, and once we have done the capsulotomy and the nucleotomy, we then bring the patient back from the laser room to the operating room. At this stage, we are careful to ensure that the capsulotomy is complete. We can see well because of the stained anterior capsule, and then you can see also that this nucleus has been well cut. Right, and this truly helps our surgery. Now, if you do not wash out all the cohesive viscoelastic completely, you may have an incomplete capsulotomy, and therefore it's important to always make sure that you stain the anterior capsule so that you can ensure a safe surgery. Now, in this patient with a posterior polar cataract, you can see the polar opacity is quite large, but the nucleus is quite soft, so I do not put fluid into this eye. After the capsule has been removed, I then put in dispersive viscoelastic just in the subcapsular plane, just where the incisions are. And after removing the nucleus in the center, we're then using our second instrument to pick up the pre-fragmented nuclear pieces towards the center to be phacoed away without the need of having to rotate this nucleus. This way, we are able to minimize the risk of posterior capsule rupture, and Dr. Vasavada, who described this technique, reduced his PCR rate to 4.4% in our study. This was reduced to 7% as compared to 20 to 30% in the past without femtosecond laser. Now, we have a more dense cataract. This can be extremely challenging, and I then increased the posterior offset a little higher, and I don't do that for a soft cataract. This is a rather dense posterior polar cataract, and we are going to handle this in a similar way by injecting dispersive viscoelastic subcapsularly in the subincisional areas. I'm not putting any fluid into the eye, and then we're going to start with sculpting a trough in this dense nucleus to create some space so that my phaco needle can sit there and crack the nucleus in the peripheral part of that trough, and then chop the nucleus against my needle in the trough and use the phaco needle to impale that nucleus and tumble it out of the capsular bag, keeping the epinuclear plate back so that the posterior polar cataract is not breached. And slowly we're able to remove the nucleus in this fashion, fragment by fragment, without rotating the nucleus, and thus not breaching the posterior polar opacity. And now, after the nucleus has been removed, we then remove the epinuclear plate by using linear vacuum and aspirating it carefully. So in this way, we can safely do the surgery without having a posterior capsule rupture. Now you can see this eye that the nucleus is tilted and is decentered, and we're scanning the capsular bag to center the capsulotomy on the scanned capsule so that the capsulotomy is centered to the capsular bag. And then following that, we apply the nucleotomy treatment. Now this patient at the operating table, you can see that the capsulotomy appears decentered, but it is actually centered to the capsular bag. We are making sure that it is complete, following which we apply traction using the capsular bag hooks so that we center now the lens so that we bridge the gap that was seen due to the lens subluxation. After creating the plane with viscoelastic just under the anterior capsule, we inject the capsular tension ring into this plane to expand the equator and keep back the vitreous and prevent the fluid from going from the anterior chamber to the retrolental space. The nucleus has been pre-fragmented and we can easily remove this without even rotating the nucleus. And at the end of the surgery, we add additional support by using a capsular tension segment and suture this with Gore-Tex 7.0, and we have a well secured and well supported lens. So in conclusion, a variety of complex cataracts can be more easily and safely managed with the femtosecond laser treatment than with manual means. And we've shown you dense cataracts, wide cataracts, fibrotic capsules, shallow anterior chambers, posterior polar cataracts, both soft and dense, and most of subluxated cataracts can be dealt with in this manner. Even the faint corneal opacities and the small pupils are not contraindications to the femtosecond treatment. However, there are some limitations, as we showed you, the patient with the granular dystrophy where the opacities are rather dense, lens tilt that is severe, or posteriorly positioned lens conditions which are not amenable to femtosecond laser technology. Thank you very much for your attention.